I'm going to demonstrate a screening physical examination. It's important to understand the context of the screening physical. It uses components of each of the system examinations to perform a rapid head-to-toe survey of all the body systems. It uses these components, but is not a complete examination of any body system. This should be able to be done quickly and efficiently using your movement and the patient's movement in a minimum way, so that you move rapidly from one position to another position, and you use your instruments as well efficiently. You'll notice as I work through this that I'm not concentrating on a single system at one time, that I'm actually moving from one to the other and then integrating all of those observations at the end of the exam into a single picture. This allows you to move quickly and smoothly from head to toe in a minimum amount of time. So we'll get started with that. I'm going to explain to you a little bit as I go through this, but most importantly, I want you to concentrate on just the flow of the examination and the efficiency of the examination. So we'll get started. Always clean your hands. It's a good idea to do that where the patient can see you quite visibly, so they know you're taking care to protect both the patient and yourself. We start in front of the patient and we just inspect. Remember, you've been inspecting the patient ever since you first saw them. So you've already done a visual inspection of the head. We can look at the scalp very quickly. Examine the ears. I want you to wrinkle your forehead up. Go like this. Stick your tongue out at me. Good. Can you hear me? Mm-hmm. How about over here? Hear that? Any difference between the two sides? No. All right, so I'm now going to move to the otoscope examination. And the otoscope is a good light source. I'm going to start with examination of the right ear. Notice that I take the tension off the cord. Okay. And the left ear. Good. I want you to look right here at my forehead. Follow it with your eyes. And up and down, up and down. Now look right here, but at my nose. Good. Look up. Excellent. Open your mouth wide. Lift your tongue to the roof of your mouth. Good. Relax your tongue. Say ah. Ah. Excellent. Thank you. Now I'm going to move to the ophthalmoscopic exam. So I want you to look right in that area. Please don't move your eyes. Good. Again, right eye to right eye with your right hand, left eye to left eye with your left hand. Look right in that direction. Look up just a little. Good. Okay, excellent, thank you. Now I'm going to palpate the skull and the posterior aspect of the neck, occipital lymph nodes. And I'm going to move to the back and palpate the anterior neck. Submental nodes, submandibular nodes, and submandibular gland. Anterior triangle down the front border of the sternocleidomastoid, right down to the insertion of the sternocleidomastoid. Posterior triangle, posterior border of the sternocleidomastoid, preauricular, postauricular, supraclavicular fossa, and the pretrapezius nodes. Thyroid cartilage, cricoid cartilage, trachea in the midline. I can feel his thyroid easily right now, but we'll have him swallow. Good, and roll the thyroid up under my hands. Put your chin down to your chest, chin all the way up. Good, chin towards me, chin to the other direction, ear to the shoulder, ear to the shoulder. Excellent. Now I'm going to expose the back. Okay, examination, and we see a lot of moles, a keloid here. Spine is nice and straight. I'm going to percuss with my fist down the spine. Any tenderness there? Looking for CVA tenderness. Any there?
Nope.
Good. Now we'll percuss. And auscultate the back. So I want you to breathe medium breaths in and out through your mouth. And out, big breath. And again. Arm to the side, big breath. Good. Arm out again, up in the axilla, big breath. Good. And then we're going to percuss and auscultate the front of the chest. Big breath. Out. And another breath. Good. Palpate the carotid. Right here at the level of the thyroid cartilage is the carotid bifurcation. Auscultate the carotid. Hold your breath. And while doing this, I'm also looking at his neck veins to see if I see any distension or pulsation of the neck veins, which I don't see. So now I would like you to lie down on your back. Good. And we'll continue the examination of the anterior chest. Be sure to expose the anterior chest, keep the patient properly draped, and we start by inspection. Looking for the point of maximal impulse, which I try to locate by noticing the pressure on the palm of my hand and then isolating that. And that tells me where to begin listening to the heart. The PMI is coincident with the first heart sound. And you listen at the apex. Lower left sternal border, mid left sternal border, upper left sternal border, upper right sternal border, and lower right sternal border. And then switch to the bell and repeat the sequence. Hold your breath, and hold your breath. Good. All right. Excellent. Okay. Now we're going to move to the abdomen. We need good exposure right up to the xiphoid, down to the pubic symphysis, looking at the contour. Auscultating for bowel sounds or bruits. palpating and auscultating the femoral arteries. And then palpating the abdomen, starting with superficial palpation. Just let me know if this is tender. And then deep palpation, starting in the epigastrium. We should be able to locate the aorta. You can see my hand pulsating a little bit there. Deep palpation into the gutters on either side of the spine. Again, rolling the tissue under your hands, looking for masses, areas of tenderness. McBurney's point, any tenderness there? Sometimes a little tenderness here over the cecum. And then we'll check for organomegaly. Percuss the upper border of the liver. Lower border seems to be at the costal margin. Take a deep breath. Blow it all the way out. Out, 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 out. Deep breath. Out. Big breath. Out. Big breath. There. Catching the liver edge right here, indicating a normal liver size. Relax. Percussing trab space, that's the normal gastric air bubble. If there's splenomegaly, it might move in that direction. Take a deep breath. Blow it out. Big breath. Checking for splenomegaly, and there's none there. Just relax, and we'll palpate the inguinal lymph nodes. Right up to the inguinal ligament on both sides. We're turning to the sitting position. And I'll move back to the front. Take a look at his hands and fingers. You can sequence these pieces of your exam to suit yourself, whatever you find most comfortable, but you need to be sure to do it systematically so that every screening exam is in the same sequence. Good. And we'll look at the legs, musculature, palpate for edema, look at the sole of the foot, interdigital spaces, palpate the pedal pulses. And notice this is a straight leg raising test on each leg as well. Just relax. Good. Then we'll check reflexes in the lower extremities. So after checking the muscle stretch reflexes, we check the plantar response. Gently stroke the sole of the foot. I use a broken tongue blade just to give, and very gentle, and we can see the toes flare a little bit. And here's a nice normal response. There we go. So it's a challenge sometimes to detect a withdrawal response. A positive Babinski sign is the most sensitive test in all of neurology. It tells you that there is a lesion in the corticospinal tract. Unfortunately, it doesn't tell you where that lesion is. I like to check vibration sense as well. This is a proprioceptive sense. Feel that buzzing?
Yes.
Feel that buzzing there?
Yes.
Excellent. And then before we stand the patient, I'll just move back up and do the reflex exams on the upper extremity. Relax your arm. Biceps, triceps. Relax your arm. Brachioradialis, and the same on the opposite side. Relax your arm. brachioradialis, biceps, and triceps. Good. Hold your hands out like this. Hold them steady. And no evident tremor. The last part is to check vestibular function. So I'll ask him to stand on the floor right in front of me. Move out slightly. Put your feet together. And shut your eyes. So he's very steady. I will now push him, see if I can knock him off balance. Lastly, retropulsion. Notice that he's standing in front of the table, so should he go backwards, he'll hit the table and not fall over. Okay, have a seat back on the exam table. Good. Well, thank you very much. That completes a screening physical examination from head to toe. During the course of this exam, I've inspected his skin throughout, so that's not a separate examination. We've checked him head, thorax, abdomen, lower extremities. At this point, in a woman, I would do the sitting breast examination. I would have done the lying breast examination as part of my check of the thorax. And a testicular exam or genital exam would be done on a male at this point while he was still standing here in front of me. In addition, fine points or extended neurologic exam, gait, would be checked at this point. But that's not generally part of the screening exam in a patient who has no symptoms. Remember to check the gait of the patient. Watch them walk into your exam room. That's a check of gait and tells you a lot about the patient. So screening physical exam can be done rapidly and efficiently, surveying all systems with a real economy of movement for yourself and the patient. I hope that's useful.